we're going to hear some more from individual hospitals this afternoon about how they're identifying and responding to family violence, and we've got some really good examples I'm sure that you're going to be interested in. So the first presenter we're going to hear from is Meghan O'Brien, who's going to talk about how family violence affects people across the lifespan. And in particular, she's talking about how St Vincent's Hospital is responding to elder abuse. So please welcome Meghan.
Thank you very much. I'd also like to acknowledge the traditional owners of the land, and I'd also like to say a big thank you to Michelle and Susan for the opportunity today to ask me to present on another form of family violence, which is obviously elder abuse. So I'm going to talk to you about the work we've been doing at St Vincent's for about the last 10 years, and hopefully today, if I can achieve any goal, it might be that there's 20 people here in the room that don't know or understand it about elder abuse, that you can actually take it back to your organisations and actually do think about older people as part of the family violence system. So what does elder abuse look like in your organisation? So based on the data and what we've been finding at St Vincent's since we've been working on this for the last 4 years, it's very likely that it could be a female aged over 80, admitted to hospital following a fall, receiving an age pension, likely to be a widow, a cold background, have some form of cognitive impairment, socially isolated, nil services, and possibly being cared for by a son and daughter-in-law. So what is the definition of elder abuse? As I said, it is a form of family violence. It is defined as any act occurring within a relationship where there is an implication of trust which results in harm to an older person. And elder abuse includes physical, emotional, financial, sexual abuse and neglect. And what I need to stress about elder abuse is that it is recognised that as a form of family violence, it does include people such as neighbours or carers in terms of abuse to older people. And I also want to stress that the difference we actually see in a hospital setting, which is a little bit perhaps different to intimate partner violence or domestic violence, is the issue about neglect when it comes to older people, and I'll touch on that a little bit more. So what does the literature actually say? Older adults who are subject to elder abuse, neglect and exploitation face a greater risk of hospitalisation than other seniors. For many older people at risk of elder abuse, the hospital may offer a window of opportunity for help and support. And we also know from the recent Royal Commission that hospitals play an important role in identifying, responding and preventing elder abuse. So why do hospitals need to consider elder abuse? We actually need to consider elder abuse because we know about our baby boomers and the generation, and in terms of the impact of older people. We also know that elder abuse does affect, it's estimated that 5% of our older people are at risk of elder abuse. So that's 1 in 20. Unfortunately, here in Australia, we don't have a national approach to elder abuse, so every state does something different, and we've unfortunately haven't had support in terms of funding a national prevalence study, but it is estimated at about 5%. We also know that elder abuse, in terms of reporting, is the tip of the iceberg. So we know many older people themselves are not disclosing abuse. And we also know from evidence and literature, and certainly from the Royal Commission, that health professionals do have a role to, in terms of responding to elder abuse. Elder abuse does start with awareness raising, but certainly what I'm going to talk to you about today is the work that we've been doing at St Vincent's, where we've actually taken that to the next level. So very much we've been supporting health professionals in terms of if they do identify elder abuse, how do they actually do assessments and what do they actually do in terms of their response. And we also know, obviously, that elder abuse has attention from the recent Royal Commission. For those who don't know, obviously for myself, who's obviously very committed to this area, I was very pleased to see that there was actually a chapter in the recommendations just devoted to older people. So what are the challenges to health professionals? We know that elder abuse does present a range of complex issues. Health professionals are very unlikely to be present when the elder abuse is actually happening, so we know it's likely to happen in the community or in someone's home. We also know from the evidence or the literature, and certainly from the feedback from the staff at St Vincent's, that health professionals are usually unlikely to act upon suspicion. We know with older people that brings a whole range of multiple comorbidities, and obviously many older people do present to hospital with a number of medical issues. There's issues around threshold of risk. So we have, certainly in our organisation, we've had a number of cases where perhaps different health professionals, medical staff, nursing staff, social workers have had different definitions, different acceptance in terms of when to actually intervene and what is the risk to the older person. We've also been told, and certainly with elder abuse, that sometimes it's just in the too hard basket. Staff don't want to ask the questions because they don't know what to do with the information. And as I said, older people are usually reluctant to report, and that's certainly evident in the literature, both here within Australia and overseas. So in terms of why are there barriers for older people, not surprising, there's a lot of shame and embarrassment, particularly because it is family members who are causing the harm to them. There's very much a fear of losing independence. If you can actually appreciate with older people, often the care is actually being provided by their children. So there's a sense that if they actually I suppose, report what's actually happening, that might mean they might have to go into care or something like that. There's a fear of retaliation, that there actually might be consequences for them. The opportunity to disclose is very, very important. I do want to stress that certainly what we found at St Vincent's, that where older people are in hospital, particularly in an inpatient bed, where they haven't got that person around them that's causing that harm or abuse, that they are opening up to staff, which is maybe a little bit differently to what happens in the community with older people. If the aged care assessment team is going to someone's home, usually the carer might be there if they're going to a GP. So certainly what we find in a hospital, that older people are reporting when they feel safe. And we certainly know that elder abuse is a form of family violence growing old. And I'll touch on our data, but what we've actually found from the data we've been collecting, that in nearly 28% of our cases, our older people are disclosing for the first time when they're actually become an older person, because they feel more vulnerable, they feel more at risk, often around discharge planning. And these are women that have been telling us often for the first time in 20, 30 years, they're actually telling us in their 60s or 70s. So what is the current practice at St Vincent's? Unfortunately, we've had no resources or funding, so everything we've done here in our organisation was within our existing resources and EFT. We certainly don't have an active screening model per se, so it's very much our usual care. But what we have done is target our education and training to frontline responders. That's particularly the social work staff in our inpatient setting, in acute and subacute, and also our care coordination staff, particularly alert in our emergency department, and I'm really pleased that Marianne is here today representing our alert team. We've also identified clinical leaders within our inpatient setting. So these are staff in terms of really being able to demonstrate highly advanced clinical skills to actually be able to respond and support older people. As I said, neglect is certainly more prominent in hospital presentations, so we're actually finding situations where carers, children might actually be refused to actually buy equipment for older people. They might actually not buy dressings and things like that. They actually might not facilitate basic needs for older people, because that might mean that they can't have access to their pension or something like that. And certainly our current focus at St Vincent's is on our repeat presentations. So we've had a high proportion of older people now who are presenting on multiple occasions, and it's about us learning how best to actually support these people. And certainly our red flags is guiding our response in terms of our ED and inpatient. So these are some of the red flags. So what we know about older people is that it might be inappropriate interactions, body language, repeat hospital presentations, as I said, doctor shopping, so we certainly find that a lot with older abuse, vague explanations, inconsistent stories, unexplained injuries, poor grooming, unexplained financial situations. So that might be during routine core assessment. A social worker might be talking to someone about a care plan or support services, and the older person might just say something that sounds quite strange in relation to their financial situation. And we've certainly had situations where there's an appearance of a new caregiver on the scene. So what does this mean in relation to practice? So I was very fortunate to get an Australian Research Council linkage grant, so I've done my PhD in the area of elder abuse at St Vincent's. I was very fortunate to do a study tour that was funded by the Department of Health, I was really able to look at the safeguarding approach of the UK back in 2010. We have an older person's vulnerable policy within our organisation. We have a model of care which includes 9 steps, and importantly, what we actually ask clinicians to do is escalate to their manager. We have a 2-person model, and we also ask staff to actually report any notifications of suspected elder abuse, and I'll touch on that. We've heard a lot about governance today, so we've established a high-level governance group that's got all our key managers across the organisation, including executive, and I'm thrilled to say that we've now got a health justice partnership. So that's been funded by Senior Rights Victoria, which is the peak body here in Victoria in relation to elder abuse. So that's a lawyer on site at St Vincent's supporting older people at risk. So I won't go a lot into detail here. Some of you may have heard me speak at other presentations, but this is the elements that we have here in relation to what we've introduced at St Vincent's over many years. And as you can see, a lot of that includes such of the things we've talked about today: education and training, culture and leadership, risk management. So just in terms of some of the data I thought you'd be interested in, we've heard a lot about data, and we've certainly used data in our organisation to actually make sure our senior managements know what's actually going on. We use as part of our education and training so we can actually see what's the prevalence, what are we actually seeing in our organisation. So as you can see, as time has gone on, as more staff have been educated and trained, as you can see, the notifications are actually going up. So in summary, in the first year, we only had 32 notifications, and that was back in 2012. Year 2, we've had 70. Year 3, we had 82. And year 4, so we're in our 4th year now, and just in the first 5 months, we've had 86 notifications. So in total, we've had 270 notifications of suspected elder abuse. So in terms of the data analysis, we've only been able to really analyse the first 184 through ethics approval. It's a very time-consuming task. We do this manually, and there's 53 categories that we actually look for. So when we actually drill down the data, we can actually see what is actually happening in our organisation. But in terms of our notifications, a high proportion of them are coming from social work in terms of the inpatient setting. Not surprising, the types of elder abuse are usually financial and psychological. Remembering that with elder abuse, often older people are experiencing 1, 2, 3 types of abuse at any one time. It's very rare that an older person will actually experience one form of abuse. So in terms of our demographic data, what we know is about 50% are aged over 80, so the very vulnerable type of older people you're actually seeing. 71% are female, and I suppose just a plug for elder abuse, I know we've heard a lot about women and children today, but obviously what we see in our organisation, what a lot of people will see in general hospitals is older people. Men are exposed to elder abuse, and we're certainly seeing that. That's 30% of our population, of our cohort at St Vincent's. 92% are in receipt of the age pension. The language we use, we don't use perpetrator in our organisation, we use person of concern. So in 35% of our notifications, it was the son causing abuse. As I said, nearly a third now of our cases do have a history of family violence. In nearly 60%, the older person has disclosed, 71% are from a cold background, and 62% are living with the person of concern. So as you can imagine, that has huge implications in terms of discharge planning when staff are actually talking to the older people. So in terms of a case study, just briefly so you know what it actually looks like, we might have an older person that presents to our emergency department. What that staff might actually do as part of routine assessment, they might determine that that person is showing some risk factors or some red flags. They'll actually do what's called a VOP notification. So that is completed by the staff in the emergency department. As part of our policy, we make sure that the managers are aware of any VOP notifications. The patient may be then admitted to the ward. There's a number of ongoing assessments, and this is what I've really focused on in terms of my work at St Vincent's, is actually taking it to the next level, so it's not awareness raising. So staff have been trained to actually do very comprehensive assessments so they can actually work out what's actually happening in that situation. As you can appreciate, with older people, we often have to do assessments around cognition, capacity, there's physical assessments, there's a whole lot of other assessments that may not happen in other situations of family violence. In some situations, obviously, there'll be family meetings depending on the risk factors. In many of our cases, we actually do what's called a VOP case review, where we'll actually invite programs, teams together to actually discuss the case. As you can appreciate, many of these cases going across wards, across programs, and obviously we then determine a safety net and a discharge plan will be implemented. Often that will be depending on patients' capacity, patients' choice, patients' wishes. So that's what it looks like. As I said, we have a health justice partnership. I'm thrilled about that. That's with Justice Connect. And I think it's been talked about today, and part of what that health justice partnership is going to be doing is really looking at the wellbeing of our older patients at St Vincent's to actually determine if the legal intervention is actually making a difference. So we have a lawyer based 3 days a week within social work department who's available to all the staff within their organisation. And just in conclusion, I suppose I just want to highlight that elder abuse is unfortunately a part of family violence. It is something that mainstream hospitals are going to see. Certainly at St Vincent's, just under 50% of our patients are older people. We don't have maternity services. We don't have children at St Vincent's. So unfortunately, elder abuse is something we're going to see more and more of. So it's really about learning to recognise the signs of elder abuse, understand how and why elder abuse may happen, be aware of your organisation's policies and process for escalation. And as I said, certainly our governance structure allows that if staff are concerned about any situations of risk, we do have a point of escalation. Provide support to older people through assessment and care planning, and a governance framework can certainly improve staff's level of confidence to act on suspected elder abuse. So, thank you.